So good morning, good afternoon. Welcome to this peer-to-peer dialogue between international experts, practitioners, academics, human rights defenders. We are looking forward to learning from your expertise and experience. Before starting, I just wanted to give a few words regarding the objective, the output and the housekeeping rules. So the overall objective of the regional webinar are to identify promising practices in addressing mental health issues in the context of the COVID-19 pandemic, and to enhance a human rights-based approach to addressing mental health issues related to COVID-19. The output of the webinar will be a snapshot of learning points based on interventions, including to help us better understanding the impact of COVID-19 on mental health, and identifying promising practices, positive experiences, and key challenges. And finally, a quick reminder of the main housekeeping rules. Please respect the time allocated per intervention. 5 minutes for panelists and 2 minutes for participants during the dialogue. Please do not unmute yourself until given the floor by the moderator, and do not forget to mute yourself after your intervention. To take the floor, click on raise hand. The list of speakers will be prepared on a first come, first served basis. After raising your hand, please wait for the moderator to ask you to take the floor. And please state your name when you take the floor. If possible, we would like you to keep your video turned on unless you have connectivity issues. The event will be live streamed on YouTube and recorded. Caption is also available. Please, to get the caption, please click on the link that will be shared in the chat. And now I have the pleasure of giving the floor to Philippe Jaffé, member of the Committee on the Rights of the Child and Professor Director of the Center for Children's Rights Studies at the University of Geneva, Switzerland, who kindly accepted to moderate this webinar. Thank you very much.
Thank you very much, Arnaud. Good morning or good afternoon to all. It is 11 a.m. in Bangkok, 4 p.m. in Suva, but I'm speaking to you from Switzerland, where it is 6 a.m. and I am thrilled to moderate this webinar. My name is Philippe Jaffé. I'm a clinical and forensic psychologist by training. And from the academic branding apparent on your screen, you know that I am a professor of children's rights at the University of Geneva, as well as a member of the UN Committee on the Rights of the Child. My job during this webinar is twofold. On the noble end, I will try to squeeze as much knowledge and creativity as possible from an amazing group of panelists and discussants, all human rights and mental health specialists. And the less glamorous task is to act as an enforcer to make sure the program progresses on schedule. And for this, I will be applying the Swiss timing method and also when necessary, rudely interrupting speakers if they get carried away. I do hope they will forgive me. The goal is to have a smooth process, help us meet the objectives that were outlined. And let me remind you of some of these objectives very quickly. In addition to economic havoc, COVID-19 has introduced an unforeseen and monstrous mental health crisis. We have a specific focus on the Asia-Pacific region. How have the mental health needs been addressed in different countries, in particular from a human rights perspective with regard to vulnerable persons and populations? If we posit there that we are no longer in a reactive phase towards COVID-19, what effective programs have been developed and implemented to help vulnerable persons and communities recover? Finally, what lessons have we learned and what will we put in place to support persons and communities should we ever meet a mental health crisis of similar proportions? And the key word here is proactive resilience. But let me at this point move to our very first panelist. And it is a pleasure to introduce Dr. Mikiko Otani. Mikiko is my friend and fellow member of the UN Committee on the Rights of the Child. She's an international human rights lawyer based in Tokyo, where her family law practice as attorney focuses on women's and children's rights. She is also commissioner of the International Commission of Jurists and a council member of the International Bar Association's Human Rights Institute. So Mikiko, you have the floor for 5 minutes.
Thank you, Philippe. In the time given, I will share the experience of focusing on the COVID-19 impact on mental health of children in Japan and some of my thoughts as suggestions. I start with a very brief overview as a context. The first COVID-19 cases were reported in Japan in January 2020. Since the first wave hit Japan in March 2020, the second and third waves have so far arrived. The government declared the state of emergency in April 2020 for the whole country, which lasted for about 1.5 months. The second state of emergency was declared in January this year for limited areas, including Tokyo, for around 3 months. Schools were closed for around 3 months in response to the first wave last year. Even under the declared emergency, the strict measures such as lockdown of the cities were not imposed. Instead, reliance on voluntary compliance with the stay home and social distancing requests was at the core of the government policy. However, the social pressures asking self-restraint has been very strong in Japan, sometimes even to the extent of self-policing against non-compliance. Economy has been damaged, severely affecting many families already in vulnerable situations. Incidents of discrimination against health workers and their families, including children, have been reported. Now on mental health. Some surveys have been conducted focusing on the COVID-19 impact on mental health, such as the one conducted in September 2020 by the government for all range of persons, including children of 15 years of age and above. However, the most notable effort focusing on children is the series of online survey conducted by the National Center for Child Health and Development, which is formerly the National Children's Hospital. This survey started as early as April 2020 and was held in June, September, and November 2020. Total of responses from 6,600 children and 22,600 parents were collected. The results presented clear indication of negative impact on children's mental health, such as change in sleeping patterns, increase in screen time, experience of uneasy feeling, difficulty in concentration, easily getting irritated, and sleep disorder. Around 20% of children reported their feeling that adults at home and school don't explain to children in simple words, don't allow children to speak their mind, or don't take children's views into consideration. The first survey conducted in November 2020 revealed the very concerning outcome that 1 out of 3 to 7 children is suffering the moderate or more serious level of depression. 1 out of 6 school-aged children conducted self-harm, and 1 out of 4 children of grade 4 and above thought of self-harm or suicide over the past week. Actually, the government reported that suicide of children increased in 25% in 2020, recording the highest number since the data collection started in Japan in 1978. In particular, the number of suicide of high school girls doubled. So now I'd like to share some of my thoughts on good practices, challenges, and suggestions based on the available information, including such survey results. Good practices. Quickness of the first survey on the COVID-19 and children's mental health and its continuation. Secondly, the interim survey results were immediately released as feedback to survey participant children and parents with relevant information on available services, COVID-19, or child rights. Third, the survey results were also quickly publicized with advice for school teachers, staff of daycare facilities, and for parents of young age children such as 0 to 5. Fourth, collected voices of children were published in series such as the title, Please Understand Children's Feeling, What Children Want to Convey to Adults, Children's Request and Advice to Adults, and What Children Are Worried and Bothered About. Finally, as a response to children's voices heard through surveys, an online meeting was held to involve children in designing the survey questions and support children to exercise their right to be heard and have their views respected. Challenges is it is not clear how widely survey results were actually known to children, parents, teachers, other workers such as child consultation centers, NGOs providing services and support to children. Furthermore, it is not clear whether the survey results and recommendations were reflected in the government measures in response to COVID-19 in such areas as support for families in need, support for school teachers, and protection of children from violence. I'm running out of the time, so I will focus and pick up just one suggestions. The practical guidance to parents and school teachers on impact on children's mental health is in easy language is needed. But I want to highlight one suggestions to integrate mental health issues in other activities such as monitoring of children at high risk of abuse, food delivery activities, and mainstream child rights into mental health related measures, including by integrating children's rights education, non-discrimination, and child participation. Thank you very much.
Thank you very much, Mikiko, for this kicking off this panel with your insights. Let me move on immediately to our second panelist, Dr. Jennifer Hall. Jennifer is a technical officer at WHO and the mental health focal point for the Pacific Island countries and territories. She supports countries to strengthen mental health service provision. And as part of her role, she leads the Mental Health and Psychosocial Support Cell under the Joint Incident Management Team set up by WHO to support the response to the COVID pandemic in the Pacific region. She is a clinical psychologist and has a wealth of experience working globally in mental health. Jennifer, you have the floor for 5 minutes.
Great, thank you very much. I'm just sharing my screen. Hopefully you can all see this. Okay, great, thank you for the introduction. Yes, so what I'm going to be talking about is the impact of COVID-19 on mental health and service delivery in the Pacific Island countries and territories. So I'll be talking about the impact and then responding to mental health needs during the COVID-19 pandemic and thinking about future suggestions. So starting off with a bit of introduction about COVID-19 in the Pacific Island countries. So they have been relatively unscathed by the virus. You can see here the statistics from today, actually, that some countries have had absolutely no cases of COVID, and some have had more. So we've had French Polynesia and Guam have had some pretty big outbreaks, and then some have had more community transmissions. Only a few countries currently have active cases. And here is the pandemic curve in the Pacific Island countries. So we can see that November 2020 was when it was the highest, and then it's reduced. And that was mostly due to these outbreaks in French Polynesia and Guam. However, the lack of there being outbreaks doesn't mean that COVID hasn't impacted the Pacific Islands, because people in the Pacific Islands have been very impacted by the virus. And this has happened because there's been some countries there has been COVID-19 transmission, there have been lockdowns in countries. What we see more of though are closure of borders in order to try and keep the virus out, which has led to there being quarantine, very strict quarantine for people entering the Pacific Island countries, with quarantine ranging from 21 days. And the facilities vary in terms of how good they are for mental health. We've seen isolation from family members who are overseas. We've seen loss of livelihoods with lack of tourism and income. We've seen fear of COVID coming into the countries. And we've also seen concurrent climate emergencies. So we've had cyclones and earthquakes happening. One of the challenges, I think, of COVID-19 and mental health in the Pacific Islands is the lack of published research looking into the impact of COVID on mental health. So there are no Pacific Island level research which is being published. However, the available data we have does suggest that there's been increase in requests for support from women and children experiencing domestic abuse, increase in people who've died by suicide in some areas. We've seen a general increase in anxiety, stress, and depression in the Pacific Islands, increased stress and burnout in health staff and people working in quarantine facilities. And we've also seen a disruption to the provision of mental health services, and this has been pretty widespread, with the biggest disruptions being seen in the community-based interventions. So that's interventions for caregivers, home or community outreach, school mental health programs, and suicide prevention. So this is a picture which is fairly consistent with the global picture of the impact of COVID. And I think something which is particularly concerning about this disruption to the community services is that these are the services which often are reaching those in vulnerable or marginalized situations, such as women and children. And we know that this population has been more impacted by COVID globally. So the response to COVID. So to overcome these barriers, we've had reports of countries using community-based outreach services. So 90% of countries have reported using these, which is great. Telehealth has been used, something which wasn't used so widely before in this area, task shifting and triaging. And then at the sub-regional level, WHO has set up this interagency joint incident management team, which is UN organizations coming together to coordinate support provided to governments for COVID. So this is the MHPSS cell, which I currently lead as my role in WHO. And what we've done here is we've been really guided by the Interagency Standing Committee guidelines, and we create a lot of resources for use by governments and countries here. So we've done some online trainings which have been adapted. We've made communication messages with this focus on reaching vulnerable groups. And we've also been trying to support community workers and specialized workers to identify and respond to mental health needs, including protection needs. And we've also created some guidance notes as well. So thinking about the future and linking it to the human rights, so linking it to Article 19 and 25 of CRPD, which I suppose are the two which are really supporting community-based mental health services. I believe that we can use this pandemic to build back better. We've had some good practice already with the more community services, telehealth hotlines, and communication messages. Some specific challenges for this region are thinking about monitoring, quality assurance, and implementation support. Yes, I could talk lots about this, but I'm out of time, so I will stop for now. Thank you.
Thank you very much, Jennifer, for this snapshot and significant information. Moving right on to our next panelist, we have Mrs. Applesta da Costa. Applesta is the program lead, psychosocial support, and at the Human Touch Foundation, a youth-based focused organization based in Goa in India. She has considerable experience with children and adolescents in both clinical and non-clinical settings. She heads the psychosocial support program for adolescents living with HIV and young adolescents with substance abuse disorders. And she works on integrating mental health care into the HIV care continuum through screening tools and customized therapies. She's a clinical psychologist as well, and she's an active member of Youth Leaders India. And Applesta, the floor is yours, please, for 5 minutes.
Thank you, Philip. Can I have the presentation, please? Good morning, good afternoon, good evening, everyone. My name is Applesta da Costa, and I work for Human Touch Foundation. Today, I will be speaking about the impact of COVID-19 on vulnerable children, adolescents, and young people, and talking about our approaches as an organization, and also giving out some recommendations. Can I have the next slide? Before getting into the impact of COVID-19 on vulnerable children, I would like to speak about the organization, just give a brief. So we are, Human Touch Foundation is a non-profit organization that works in the state of Goa, India, and we work with the youth for the youth. Our mandate areas of work include sexual and reproductive health, HIV, tuberculosis, and substance abuse. So the services that are rendered to our clientele, they are strategically tailored to ensure that all young people have access to good health, well-being, and human rights. Next slide. So the impact of COVID-19 on vulnerable children. During the early days of the pandemic, we saw that when every single individual was caught up in the chaotic mess of understanding and reacting to the COVID-19 outbreak, mental health concerns had taken a backseat. And during this time, mental health issues that were already existing or those that rose as a result of the outbreak were not considered an emergency. And children who were availing therapies such as behavior therapy or play therapy, they regressed. While other young adults who were on psychiatric medications, they relapsed as a result of unavailability of therapy sessions and psychiatric medications at hand. And some of the mental health issues that arose among these vulnerable children and young adults were commonly anxiety, depression, stress, fear, and confusion. Due to restricted movement due to the lockdown, families belonging to vulnerable communities face unemployment, as majority of them belong to the category of daily wage workers, and financial insecurity increased the burden of anxiety as these groups did not have access to the basic food and hygiene needs. Parents and guardians and caregivers fear that they would face malnourishment as they anticipated that they wouldn't be able to provide for their families if the state of affairs surrounding COVID-19 did not change soon. COVID-19 also caused a disruption in the educational sector, with teaching shifting to an online platform, and children and adolescents coming from poor families, they were significantly affected by the school closure, which only exacerbated the learning crisis. And children and young people from the vulnerable communities, they experienced negative impact on their mental state as they were unable to access electronic technology, which contributed to high levels of anxiety and stress among them. Next. Closure of schools and workplaces saw an abrupt change in the routines and habits of children as well as adults. And children began to exhibit behavioral and emotional changes due to home confinement and social isolation. And parents and caregivers who were frustrated with their own set of issues, they were not able to deal with these changes. And children's and adolescents exposure to idleness and the parents negative approach to dealing with these changes, they only aggravated negatively on the mental state and gave rise to interpersonal issues among the families. To cater to the increasing number of patients getting infected by COVID-19, all hands were taken on deck. And we saw that health staff, especially those working in the hospital setting, they saw themselves being appointed with new responsibilities. And this also included engaging mental health professionals to do this new, take upon the new responsibilities, which included delivering services to COVID patients, which were, apart from the counseling sessions. And during this time, clients of the concerned mental health professionals, they experienced abandonment, and counselors and therapists were able to provide only limited time to their clients, and only clients that were considered to be in an emergency situation were given a chance to attend therapy sessions. So we see that the pandemic had a detrimental effect on children as well as adolescents who are also accessing long-term treatment for chronic conditions. Next. So our approaches towards COVID-19 vulnerabilities, a hybrid model of mental health care services was adopted to deliver psychosocial support. And in order to tackle the mental health issues that arose as a result of the pandemic, interventions incorporated a combination of telephonic and in-person counseling sessions. an eclectic approach was taken into consideration where strategies from varied psychotherapies were tailored to address the issues presented by the clients. Owing to the limited cognitive capacity or comprehension ability of vulnerable children and adolescents, simpler strategies were adopted to tailor the interventions. Wherever required, we also engaged family members and caregivers in the intervention so that therapies had a greater impact.
Applesta, you have to wrap up, please. Thank you.
Next slide. So I'll go straight away to the recommendations. Insurance coverage for mental health should be given focus, especially as outcomes due to abuse or drug of alcohol and drugs is excluded from insurance plans. And besides that, treatment-centric approaches, preventive and promotive aspects of health, mental health should also be taken into consideration. And one important lesson that COVID-19 has helped us recognize is that all basic human rights are interdependent. And if any one realm of an individual's life is affected, it automatically has a negative impact on the other areas. So we need to make proper referrals and linkages if we need to keep a balance of the biopsychosocial continuum. Can I have the last slide? Thank you.
Thank you very much. Sorry to rush you along a little bit, but we are on a schedule. Thank you again for your recommendations, and I will skip. We will go on to Professor Liu, if he could join us, and I would like to introduce him. He is a distinguished colleague from another UN treaty body, the Committee Against Torture. He is a professor of international human rights law and currently the deputy director at the Institute of International Law of the Chinese Academy of Social Sciences. He is notably also the executive director of the same academy's Center for Human Rights Studies. I also note that he has extensive experience in humanitarian law, but also with regard to the protection of vulnerable populations, such as disadvantaged children and victims of trafficking. So, Professor Liu, if you would please take the floor for 5 minutes.
Thank you, Philip. Thank you very much for your kind introduction. Also, I want to thank the organizers to make the significant regional meeting take place virtually. COVID-19 is a threat to the right to life and the right to health. It poses a challenge to the government and the society, as well as a test for protection of human rights for all countries and other actors. The UN Human Rights Treaty bodies ourselves have been impacted a lot, and many sessions, meetings have been cancelled and all held online. Different treaty bodies strive to play a role in crisis, reminding state parties and the international community to protect human rights in response to the pandemic. The Committee Against Torture requests all countries participating in state report procedure to explain in their report or replies how to prevent and prohibit torture or other ill treatment. Particularly, my committee requests the state parties to specify the measures taken in relation to persons deprived their liberty and in other situations of confinement, such as in homes for the elderly, hospitals, or institutions for persons with mental or psychosocial disabilities. There is an inter-treaty body working group on COVID-19. My colleague, fellow member of the Kant Committee, His Excellency Ambassador Erdogan Askan, participates in the meetings actively. According to the UN Covenant on Civil Political Rights, Convention Against Torture, and the international customary law. Prohibition or torture is absolute and belongs to the non-derogable rights and cannot be limited at any time. All people, including ordinary people, women, children, the elderly, and the disabled, have encountered mental health challenges during the long spread of the pandemic. The pandemic itself, coupled with the mental health challenges caused by it, has sharply increased the pressure on protection of the right to health. Governments of all countries have the responsibility and obligation to protect all basic human rights under special circumstances. To this end, we must respect science, rule of law, and human rights, and rely on professionals and the power of the whole society. I note the work of China's Association of Persons with Psychiatrical Disabilities and their relatives. The association plays an active role since the outbreak of the COVID-19. It calls attention to psychological challenges of mental patients with its constant appeal and efforts. In addition to the ordinary psychological hotlines, telephone hotlines related to mental patients have been added in many cities. Through this channel, they try to find the persons in need and lend a hand to them. The media, especially social media, is very important. Some cases of human rights violations including cases concerning excessively strict epidemic prevention measures which exceed legal boundaries and constitute torture or other abuses were promptly stopped due to media exposure and social media attention and follow-up. For example, in January this year, in a rural village in Hebei province, China, after the outbreak, the villagers were not allowed to go outside casually. On 19 January, an old man wanted to go out to buy cigarettes at the grocery, but was stopped. He refused to listen. Then the village leader asked the young man to tie the old man to the tree and scolded him. After being exposed by netizens, the elderly was rescued in time and the related personnel were punished. To deal with the health crisis, both scientific methods and legal methods are important. Respecting and protecting human rights is a challenge to all countries. All actors must reach a consensus and put it into action. I stop here.
Thank you very much for respecting the time allotted to you and for those insights as well, which I think are very important with regard to the effects of the pandemic. I would like to ask Professor Changrok So to take the floor. He is also a UN Treaty Body colleague from Korea. He's a member of CCPR, the Human Rights Committee, which monitors the implementation of the Covenant on Civil and Political Rights. Changrok is a professor at Korea University Graduate School of International Studies, and from what I understand, an active fixture of human rights, both in the academic world and in practice, as he is also the president of an NGO, Human Asia. He has contributed to development and emergency aid projects, and also to the protection of the human rights of migrant workers. Changrok, would you please take the floor for 5 minutes? Thank you.
Thank you very much for your great introduction. It's a great honor for me to join the seminar. First, I'd like to share some of my personal experience with you regarding the mental health impact of COVID-19. Maybe speaking not as a human rights expert, but as a COVID-19 patient. Last year, after visiting New York in March, I was diagnosed with COVID-19 on my return to Korea, and I was hospitalized and completely isolated for 3 weeks. At that time, I suddenly became a virus carrier from abroad rather than a professor or a UN human rights expert, and was simply numbered 13th patient in Seongbuk province in Seoul, in Korea. The government started to investigate my personal information and trace my movements, and these were later published online. This information was even reported in one of Korean newspapers. Even though this collection was legally allowed, in Korea, I felt that my privacy rights were heavily infringed upon. I also experienced, to a certain degree, stigmatization, discrimination, and marginalization. One of the most challenging difficulties I had while I was in the hospital was related to mental health, especially panic disorder, which I had never had before. Very fortunately, the hospital I was in had many experiences in caring for patients with infectious diseases. So every morning, a doctor called me to discuss my mental health status and prescribed proper medicines if necessary for treatment. I think this was very helpful for me to fully recover. I'm so lucky that my hospital had that experience with these problems. But obviously, not everyone was so lucky during this pandemic. From my experience, I'd like to make several points on the relationship between pandemic and mental health. First, we should know that many patients and their families are facing serious mental health problems during and after the pandemic. As you know, Korea had many MERS patients in 2015. Many of them died, but there are a lot of survivors, and many survivors are still suffering from mental health issues. 70% of them, I heard. Second, due to the stigma associated with mental health disorders in Korea, and most likely elsewhere, people have a very difficult time speaking out about it publicly. They are worried about losing their job or becoming a target of stigmatization and discrimination. So if a person can awareness and seek proper treatment promptly, it would be much easier to get recovered. And third, many people do not care much about the difficulties that patients are experiencing both physically and mentally. I can understand it in part, since everybody is looking out for themselves during this pandemic, but this lack of empathy can lead to a worse situation in whole society during and even after the pandemic is over. And lastly, this is about the impact of new digital technologies on mental health. I have conducted a research on this issue as a rapporteur of a mandate in Human Rights Council Advisory Committee for the last 2 years. And new digital technologies offer an exciting way to tackle some of these problems, but they are also a source of concern. Digital provision of healthcare services have enabled our medical systems to avoid collapse, but we must not overlook how intrusive these services can be and the unique threats they pose to mental well-being. For example, some of my foreign students in Korea have reported how mandatory quarantine apps on their phones when they first arrived in Korea created high levels of anxiety, even blaring an alarm if it was left untouched for a long time. This function ensured that students did not leave their phone and sleep outside to explore. Digital tools are very effective in stopping the pandemic, but we should not normalize high levels of individualized surveillance and remote control of human subjects. To conclude, Although many are aware of physical symptoms of this virus, there is a gap in understanding the potential mental health issues. Unlike in my case, there were many people who had their mental health issues dismissed or overlooked. The right to mental health is fundamental, and mental health care component needs to exist alongside with the biological fight against the pandemic. I'll stop here. Thank you very much.
Changrok, thank you very much for sharing your personal experience and tying it to the overarching issues that we're contending with in a systemic realm, dimension. What I would like to do is open up to the discussion and open up to all the participants that are mental health specialists and human rights specialists. And in that case, ask them to intervene and to bring their experience as to what they observe from their own perspectives in the many countries they represent with regard to best practices in terms of the impact of mental health, of the pandemic on the mental health of the persons they deal with and communities they deal with. So at this point, if anyone would like to take the floor, you're supposed to raise your hand in the appropriate chat box, and we will give you the floor. And you have 2 minutes to provide your insights. So let me read out the first question. Can you speak about the way you have incorporated cultural elements in your mental health interventions implemented during COVID-19? I guess I would address this question to Jennifer, as she has been working on a inter-regional level with several countries. And I don't know if you could speak to this very briefly.
Yes, I certainly can do. So yeah, we work across 21 different Pacific Island countries and territories here in WHO, and we do quite a lot of adapting our materials to make them relevant for this region. And in order to do this, what we normally do is we work very closely with end users. So that's people who are going to be using the materials. So materials we've designed for community workers, we work very closely with community workers to find out about their situation and exactly what they need. And then we do interviews with them, and we adapt the materials with people from the context. So very much incorporating their perspectives and what they want to be used. We often do adaptations such as changing the pictures to be pictures of Pacific Islanders. We also change the word, and we've also, here in the Pacific Islands, there's a community approach to almost everything. Like people very inherently sit around in groups and they talk about things. So we've also adapted some of the interventions to be done in this kind of way of sitting around and talking to really try and incorporate how things are. So lots of adaptations and lots of talking with people and listening and testing as well, testing our materials and adapting based on feedback.
Thank you very much. Thank you for that. If I could ask a follow-up, have you also been attentive to the issues that regard ethnic minorities, language issues, perhaps religious minorities as well? Is that factored into how you approach the work you're doing? Mm-hmm.
So the way that we very much work is we support countries to do the adapt. So we will do some big adaptations at a Pacific level, and then we support countries to be doing more minor adaptations. So all the countries and organizations can take our resources and adapt them as they see fit. So when it comes to more specific minorities, we've definitely been thinking about how to include them, but it's more working with people on the ground to do that. And they will, so that's how we do that.
Yes, If you look at me, if you see me peering to the side, is that I have a second screen. So the next question that I've received is, what is the best psychosocial intervention for human rights violence cases, torture cases by virtual method in rural settings? My fellow panelists, you see the question in your chat box. Perhaps I could start with you, Huawen, if you would like to address this, because you did bring it up in your remarks. Otherwise, we can also go to another panelist if he or she feels comfortable.
Excuse me, do you give the floor to me?
Yes.
Thank you so much. Yes, I noted the question from friend Nepal. It's quite a good question, and I see China is also a developing country, especially we look at the situation in rural areas. Like other Asian countries, nowadays the mobile phone is used a lot. I see the netizens, now the netizens could play a very important role in identify the persons in need. So it's crucial that the authority could facilitate, set up and facilitate the mechanism, the channel to hear the voices, to get the reports for the torture cases, and also for cases concerning domestic violence, for abuse of children. The authorities, the police should be easily get the information. So even in the rural areas, now people easier than before to use their phone to report to the police, to the authority. And sometimes the vulnerable groups, the mental patients, their relatives, they unite online, and they support each other. They make their voices heard by the public, by the authority. So the new technology is quite useful. And then it's the responsibility and obligation of the state parties, the governments, to carefully listen to the voices. But still, even in cities, some old people, they are not good at using the phones, the internet. So still, the community level is quite important. So at the very basic level, the social workers, the persons care, the vulnerable groups can play important roles.
Thank you very much. I would like to give the floor for 2 minutes to Dr. Prabha, who asked for the floor, and we would be interested in hearing your experience in the field. Thank you.
Thank you, Philip, and that was such a great panel. I want to raise some of the issues that Dr. Changrok raised about the personal experience of a person's facing COVID and the mental health aspects, and I think he brought it out so beautifully. One of the things I think which has happened, which has not got enough attention in mental health, is the disenfranchised grief, because there have been many bereaved people, particularly in India. There have been lots of deaths. And because of the nature of the death, it was stigmatized, it was isolating, people were not allowed to do rituals. I think there's a big group of people, friends and family members, who have not dealt with their grief, and we are trying to develop protocols to help people dealing with the kind of grief that they have felt, which has not been processed And I think that's a problem which is there in mental health issues. The other thing that I think I would actually like to commend WHO and Jen Hall's website, which we really used a lot for the interventions that we did, and we derived a lot of inspiration from that, and it was very good that WHO acted quite fast to bring out these things. The government of India did a few things to improve mental health. They brought out something called a COVID psychosocial helpline within a few weeks of the COVID starting and around the time of the lockdown. While that was a great laudable effort, I think we didn't have experience in managing such a big psychosocial helpline, which is a national helpline. And over time, people who were holding the helpline actually dropped out and probably didn't get enough supervision and support. So I think one of the things that WHO and other organizations can help is by developing protocols and methods of how to run these hotlines when the demand becomes overwhelming, both for data collection, learning, supervision, as well as actually holding these helplines. Personally, for me, I work a lot with women, pregnant and postpartum women. So as soon as the pandemic started, we started talking to the obstetricians about the kind of problems the women were talking to them about, and brought out a guidance note for obstetricians, midwives, and nurses about how you can handle the questions that pregnant and postpartum women have. And a lot of them found it quite useful. We also started talking to women, the counselors in the one-stop centers who were dealing with domestic violence, because there were no guidance notes about how do you handle the concerns about infection. If a woman comes to a one-stop center for shelter, what do you do? Do you test? Do you take them in? How do you prevent other people, mothers and children, from getting infection? There are still no very strict guidelines about this. And these are some things that I think, it's a learning, it's a process, I think. And someone mentioned the whole problem of skilling people in technology and providing cheaper internet. I think the moment we turn digital, the problem is that only those people who have access to technology or who have skills in technology get the services and the other people don't. And I think that's something that government should really start working on, to get cheap internet, get smartphones which are cheaper, and motivate people to learn, particularly older people and people with low literacy. So these are some things that I would like to emphasize: special needs of the elderly, women facing violence, pregnant women and postpartum women, the grieved and the bereaved lot who have not got services at all. And then about what we can plan for the future, sort of better helpline and hotline planning is something that we need. We need more guidance on this, I think, in terms of mental health issues. So as a professional, while we try to do a lot of things, I think that planning things much better and not doing just knee-jerk reactions, also collecting enough data. I don't think the services have to collect it they had the opportunity, but they didn't collect enough data to be able to understand what we can do further. So I think more guidance around this would be very, very useful.
Thank you so much for thank you so much for these highlighting these issues and your observations on the technical aspects which accentuate inequalities. I'd like to give the floor to Abu Sayed, who had a few questions and observations also on these technical issues. Could you please take the floor for 2 minutes? I see he's online, but he's not microphone open. So at this point, we have a question from, okay, I will read his question. He is wondering if during the COVID-19, telepsychiatry is becoming popular in many countries, and what are the benefits of telehealth in general and telepsychiatry in particular, and should it be encouraged even when we're beyond this pandemic era? So anyone who would like to answer that or you can keep it in your back pocket as well, and we can come back to it at some point if you want to think about it. And at this point, what I'll ask is if Mikiko Otani would like to take the floor. She had some observations and a question to ask as well. Mikiko?
Thank you very much, Philip. I have a question to Jennifer, because in your presentation, you mentioned that in the Pacific countries, the people are also worried about the typhoon or cyclone hit. And also, I understand that there were also other diseases spread. So my question is, because the CRC Committee on the Rights of the Child, very often make recommendation to the states to develop the disaster risk prevention plan involving the children. So my question is, what do you think about the need or appropriateness of integrating the plan in response to the pandemic in a broader disaster risk prevention, in particular with the consultation with the peoples who are mostly vulnerable, such as women, children, elderly, or the persons with disabilities for the future activities or these suggestions? Thank you.
Thank you, Mikiko. I think that's a really good point and a very good question to be asking. The Interagency Standing Committee Mental Health Reference Group, who are the ones who have put a lot of the guidance out around the pandemic mental health response, they actually do recommend to include people in vulnerable or marginalized situations in the planning of the pandemic response. Particularly, I think it's their guidance note on older adults talks about, doing that too. I think it's a really good idea. I think that when designing any form of response or policy, it's always good to have service users or people who will be impacted most directly, particularly people in vulnerable and marginalized situations, in that, particularly as I think there's so many barriers to reaching these people, and anything which can be done to help overcome that is really important. That's really great that CRC are doing that. I think it's a really good idea, and I'd love to hear any examples of anyone in this group has done that and how best they've been able to incorporate, like people from vulnerable and marginalized situations in planning.
Thank you very much, Jennifer. I would like to ask Changrok to take the floor. He wanted to intervene as well.
Yes, thank you very much. I just want to briefly make an intervention on the question of telepsychiatry, because the question is very important, and basically I think it should be encouraged even after the pandemic, and it will help the patients or the other people who are suffering from the mental disease. But important is that remember is when private companies or governments doing this, they collect data. They can have the personal informations, and if we don't regulate or control how they collect data and how they use the data, the negative consequences can be really high. In terms of new digital technologies in general, a lot of countries are adopting the new technologies and preventing the spread of COVID-19. It's very positive. But on the other hand, there are a lot of negative consequences. But now in the pandemic, government and people tend to disregard the danger of the negative consequences. So I think we need a so-called human rights impact assessment in every policies and every measures in the countries. Okay, that's it. Thank you very much.
Thank you very much. I'd like to extend my comments on what the point you just made. The Committee on the Rights of the Child just came out with a general comment on children's rights in the digital environment, and we are certainly very aware of some of the negative outcomes of how digital technology can be used, and data collected and privacy ignored and sold to third parties, and stigmatize children long-term, even when by the time they become adults. I think your point is very well taken, but I also would like to underscore the positive aspect of these teletechnologies and the digital opportunities, which is to break isolation. And I've seen also a few groups around the world who have been set up to increase contact between, in an organized therapeutic way, in particular in youth that have been released from detention centers but are still monitored, and to keep track of them within the community, but in an empathic way. And I just wanted to underscore the use of the word empathy that you raised before. So there's the negative side and the risks, and the impact assessment should always take place, but there are also some really good aspects as well. I also see that there's a hand raised by a still unknown participant that goes by the code name Galaxy 30. If Galaxy 30 would like to take the floor, please do, but also identify yourself so we can become a little bit more personal.
Good evening, everyone. My name is Rudy Senicula from the Pacific Disability Forum, and this has been a very interesting webinar. So when following on the national and regional news around the Pacific, we can say that the Ministry of Health has been receiving a lot of reports from communities requesting for community church leaders to support them on training on mental health, as well as on psychosocial support and anxiety with community members on COVID-19. For persons with disabilities, there is a lot of anxiety, fear, and sleeplessness that has been faced during this pandemic, low mental well-being, and the difficulty in receiving medical treatment during lockdown, and also the disturbance of social support that has been provided to persons with psychosocial and intellectual disabilities during COVID-19. And persons with disabilities find it very challenging and difficult in practicing the 8 preventative measures effectively. And for example, when we talk about social distancing for persons with disabilities, this is very difficult. For example, for persons who are blind or have low vision or have vision impairment, and also for those that have persons with disabilities that are on high support needs. This category or these groups of persons with disabilities will need support, or will need a support person or a personal assistant with them most of the time or at all times. And practicing some of these preventative measures is very difficult. And also for washing hands, for example, for washing hands, persons with high support needs, persons with psychosocial and intellectual disabilities need constant reminders with the use of pictures, with the use of simple language, or with practicing these steps every day that will help them to remember that this is the safe way of practicing this preventative measure. So we are very grateful to WHO, who has stepped in and provided funding support to the Pacific Disability Forum that enabled us to carry out a project with our member disabled people organizations around the Pacific. And this project is basically looking at awareness raising on the IAC materials and also on videos. So we have developed a few IEC materials, a few pamphlets and posters, and also a few short videos, basically on showing how to safely practice the 8 preventative measures for persons with disabilities and their families. When the COVID-19 hit Fiji, for example, many persons with disabilities became very worried, had a lot of fear in them. and even their carers did not know how to provide that continuing support to persons with disabilities during the pandemic. So one component of this project is looking at community awareness using the IEC materials and the videos, and we share this with our disabled people organizations around the Pacific. And if they see that there is a need to contextualize these materials into translations, then they can go ahead and do that, and they use the IEC materials in the community awareness. Another component also is we're looking at the linking of our DPOs with the Ministry of Health in country, so that there is joint collaboration on the work around COVID-19. So when there is when the DPOs are going out into the communities, they are able to invite Ministry of Health personnel to come along with them and to also participate on their awareness on COVID-19. And also when the Ministry of Health goes out into the communities, they are also able to invite representatives from the DPOs to come along with them to do the awareness. And currently we are working on a vaccination guide with the WHO. So this guide is basically an information guide for persons with disabilities, talking about what is vaccination, the different types of vaccination that's available, how to prepare persons with disabilities when going to take vaccinations and all that. And we'll also be producing short animated videos on this vaccination guide.
Oh, sorry. If you could wrap up so we can move on to other issues, but please go. Okay. Conclude your thoughts.
So these videos will also be simplifying to persons with disabilities the different things or the steps that they need to take or prepare for when they are going out to take their vaccination. So this is what our organization has been doing so far with preparedness on COVID-19 for persons with disabilities. Thank you.
Yeah, well, thank you so much, because obviously the community of persons with disabilities face unique challenges. And I would like to underline one of the personal learning elements that comes out of this COVID crisis for myself, is that we have to think of societal resilience in preparedness. And there is no reason why all these lessons learned can't go into making sure that specific communities are not left hanging when a new pandemic occurs or a new crisis occurs, and we will be prepared, and we don't have to take all this time to find the right reactions. Thank you so much for your intervention. I think we also have an intervention request from Dr. Odile Chang. If you would please take the floor for 2 minutes.
Yes, thank you so much for the opportunity to participate in this forum. I just wanted to comment on the telehealth for mental health. In Fiji, we've had a very good experience in the sense that we were able to partner with the Ministry of Health and with the St. Vincent Pacific Health Fund to be able to get equipment, telehealth equipment, to help our nurses and doctors to be able to liaise with their patients and the relatives, as well as with their colleagues in more isolated areas. And as someone was asking whether this is something that should be continued, and it's definitely something that the mental health team here in Fiji will be taking up. And just very briefly, I wanted to just comment that even outside of COVID, I think one of the things that needs to be done in terms of human rights is that, you know, there needs to be help in, I think, supporting countries in the implementation and enforcement of the policies and legislations that they have in place for mental health. And also just to go back to the telehealth, is one of the setbacks is, of course, trying to maintain confidentiality and having policies in place. And so if there are organizations who have expertise in this area, I think that is something that should be considered and given to our developing countries. Thank you.
Thank you very much for this. at this point, we can go back to Dr. Chandra. If I think she would like to bring up an issue with regard to suicide prevention. If you could do that briefly.
Sure. I think one of the things that has probably been very important and flagged in most countries is the high rates of suicide during the COVID pandemic. And obviously this might be due to many reasons, including economic reasons, COVID-related stigma, inability to access help, social isolation. I think that India for example, now is looking at the National Suicide Prevention Strategy. And I think this is a very good opportunity for us to learn from countries worldwide about what works. For example, in Brazil, a recent RCT, which was published in The Lancet, actually found that cash transfers are a simple way of actually decreasing suicide rates. So I think that, not looking at suicide only as something which has to do with mental illness, but to do with mental health, and using a scaffolding approach where we try and identify vulnerable populations and develop services which are both social, structural, as well as mental health, which can help in scaffolding. And so I think I just want to highlight this issue because in India, we are facing a fairly high increase, sudden surge in suicide rates among young people particularly. And I'd like people to respond to how it's being handled in other countries.
Yeah, we have very clear data in Switzerland on how the economics insecurity really does increase the suicide risks among young people in particular. Ms. Tarasini Siva, would you like to take the floor? 2 minutes max.
Hi everyone, good afternoon. So just a brief background. So I'm from Malaysia, from Health Equity Initiative, which is a non-profit, non-governmental organization serving the refugee and asylum-seeking population through a range of clinical and non-clinical mental health and psychosocial interventions in here, Kuala Lumpur, Malaysia. So back then, the first COVID-19 case in Malaysia was detected in January. The detection of COVID-19 among refugees began with a major cluster where there was a number of refugees who joined the religious gathering, which then contributed to mass targeted testing of migrants in certain areas, then which led to raids and continuing arrests of foreign nationals without documentation. There was also COVID-19 cases and clusters detected in immigration centers, and also a wave of xenophobic and hate speech leveled against migrant communities. Hence, on top of the factors contributed by the pandemic itself, these factors also further contributed and impacted the mental health and psychosocial needs and condition of the refugee and asylum seeker population. So what happened during this period of time, we also noticed that the impact on the level of access to income, which then affected their access to basic necessities like food, healthcare, ability to pay rent, of all which increased their stress, on top of the existing mental health issues due to their experience going through war and violence in home country and the ongoing stresses here. So some of the interventions that we adapted during this period was we prioritized the activities providing care to the patients on a virtual scale and responding to their emerging needs of the population. These interventions are also based on partnership building and complementing roles with other non-governmental organizations, coalition and governmental agencies that allow the distribution of skills and knowledge and widening the community impact. In terms of mental health services, we focus on pharmacological treatment. Other than that, we also added more treatment adherence support via follow-up phone calls, including psychoeducation and monitoring of their medications. We also conducted the therapy and counseling sessions online. And another intervention that I would like to share here was the online support group sessions, which was very impactful as it addressed the social isolation that was happening during the lockdown. So it created a platform to come together to share their concerns and their mental health condition, as well as receiving information from each other regarding the situation, which to certain level, it also addressed the uncertainty during the pandemic. Other than that, based on the MHPSS model, we also saw the need to address the basic needs, right? So we collaborated with other organizations and individuals in providing donations for food and non-food provisions and other psychosocial support interventions in relation to health, getting them the access to get tested and anything of that sort. We also conducted COVID-19 symptom screening calls for our patients and also community members via contact tracing. The purpose was to ease early case detection and to facilitate the further action plan that they can do followed by that. And we also created IEC materials, which then was translated to 7 languages so that the information would reach the community members. The IEC materials were based on COVID-19 related content, updates from the government, and also materials that promoted psychological and mental well-being.
I have to ask you to wrap up. I'm sorry. I hate to interrupt you.
That's fine. I was almost going to wrap up. So these are some of the interventions that we adapted during this pandemic to address the needs of this community, in specific the refugee and asylum seekers community in Malaysia. That's all.
Thank you so much. Everyone, we have 3 more speakers, and I would like to all 3 of them be able to intervene. We start with Judith Blanc. If she would really keep her remarks brief, because we're running out of time as the discussion heats up. Please take the floor.
Good evening, everyone. This is Judith Blanc from NYU. I'm a researcher in the field of disaster mental health. So what I would like to emphasize today is the importance of the culturally tailored intervention and also community, right? Community resilience. I concur to everything that you have shared so far. However, as an author of a mini review on Vietnam response during COVID, right? So we have identified some, natural coping, some cultural tools in Vietnam, in the Vietnam nation and Vietnam community that technically you don't even have to develop a specific intervention, a specific mental health intervention, right? To offer, let's say, let me rephrase what I wanted to say. I want to put emphasis on the fact that right now it is scientifically proven that even without a therapist, right, a formal therapy intervention to help people cope with COVID, you can leverage some cultural tools in the community, such as, philosophy, right, such as caring, solidarity, right, altruism. You can leverage that. We can reinforce that to also fight against the negative outcome of the exposure to the COVID pandemic. So I am inviting you, I will share with you a paper that I co-authored with a student of mine. So the paper, it's about Vietnam response during COVID. So this is the link.
Thank you.
Just in case in the future, for those of you who are working in with the Asian community, right? In case you want to leverage tools in the community, to help people cope with the exposure to the COVID-19, I would invite you to read this paper. In this paper, we are putting emphasis, we are underlying a lot of cultural tools in the Vietnam philosophy that can be a buffer or a resilience factor to help people cope to the pandemic.
Judith, I have to interrupt you because we want to fit in 2 more speakers, but thank you for highlighting these cultural and human touch aspects as well. Rosemary Case, please, you have, I'd say just about a minute, if you can be quite concise. Thank you.
Good morning, Philip. I will try to be as precise as possible. I just wanted to pick up on your point about building back a much more resilient community where in the Asia Pacific, there are countries with developed mental health systems that incorporate institutionalized based care or enforced institutional care. We need to move away from institutionalization. The experience during the pandemic was one where risk levels were heightened extremely, and people in institutions were at much heightened risk to catching the being exposed not only to the virus, but also not being able to access critical respiratory care outside the institutions, and were highly represented in the numbers of the cases of deaths within countries. So we need to move away from institutionalized care and have much more resilient communities post the pandemic and post institutionalization. And thank you very much for the interesting webinar this afternoon.
Oh, thank you so much for this. And just to mention that you are a member of the Committee on the Rights of Persons with Disabilities and a colleague of ours, and thank you for that. Mikiko Ueda would like to intervene, I presume, on the issue of suicide, but
yes,
I'm not sure.
Yes, I will be very brief. I just shared everyone with my slides that shows the number of suicide deaths in Japan. Well, sorry, let me introduce myself. My name is Mikiko Ueda. I'm a suicide specialist in Tokyo. So what we have seen in Japan is that, as Miss Otani said, we have having a very mild lockdown, no strict lockdown or strict movement restrictions, but number of suicide deaths in 2020, in the second half of 2020, have increased quite a bit, especially among women. If you look at the figure 2 of the slides, later on is fine, but you see that the number of increase is particularly large in female. And then also, if you look at the figure 3, that it's mainly among young women, and then also children, the school children as well. So I just want to raise awareness that the women are most vulnerable during this pandemic in terms of the suicide death. Thank you.
Thank you very much. A next and final speaker, I would presume, Asita Alengo. Asita?
Yes, I'm here.
Would you present yourself, introduce yourself as well?
I'm Dr. Asita Alengo from Indian University College. So I'm working as a lecturer. So my friends and I conducted a research on comparing the online classes between the face-to-face classes. We found that 85% of students prefer the face-to-face classes compared to the online classes. They prefer to come back to the campus. They want to see their lecturers, their friends. So, and some students, they don't effort to buy their laptops and smartphones. And some students cannot get the good internet service. So Malaysian government take efficient steps to overcome these problems. What they did, they come up with they provide the COVID-19 hotline number specifically for the people who suffer with the mental health problems. So they can share their any problems with their, maybe they are depressed or sad or anger, they can share with the person, okay, through the hotline number. And beside that, they give free internet service during the COVID-19 pandemic. And also, moreover, they give also like a free smartphone for the poor students. So everyone can get back their education. So this is the one come from our Malaysian countries. So that's all from me. It's a very brief.
Thank you very much. We're reaching the end of this webinar, but I would like to, before we conclude, if any of the panelists would like to react with a 10-second takeaway from their side of what they heard, what they'd like to react to, and then we'll move on to a very brief conclusion. Any of the panelists, would they like to take the floor? I think at this point you should just go ahead and skip the raising the hand. Anyone? 10-second takeaway. Let me start, because I heard so many interesting things here, and so I'll anticipate some of the conclusions. I heard references to the need to to gather data, evidence-based data, that telehealth and communication methods were helpful in this regard, but we have to be wary of the dangers, make impact assessments. So data, technical responses are really helpful. I heard about community responses. I heard about governance improvements, interagencies, collaborations, and improving provision of services to specific communities, but in general as well. I thought a very important highlight was to speak about the importance of the media, not only in terms of exposing issues, but also in terms of highlighting, unfortunately, negative aspects, but also using a personal experience with encroachments on privacy rights, but also perhaps, as Changrok brought up, personal testimonials can also be quite useful in a pedagogical perspective, and I think that's something that needs to be harnessed much better. And of course, we heard a lot about the very great distress and that is occurring and for many people, whether it's direct distress and the increase in suicidal behavior, and that's, I think, a global issue, but also in the after effects of the COVID pandemic, long-term effects, not proper grieving, lingering symptoms, feelings of isolation that are not evacuated, and so on and so forth. So there are so many things, and I took a lot more than 10 seconds, and I still have a very brief conclusion. But if there's anyone else who would like to intervene, please feel free. Changrok, I see you approaching the camera.
I'll just make a brief 10 seconds comment. As I said, the mental health issue is extremely important concern we should pay attention to in this pandemic. And we are using, and we have to use digital technologies to solve these problems. But on the other hand, there are pros and cons of this using these technologies. So we have to keep in mind that there's a possible negative consequences of using those technologies. Now, otherwise, our future of human rights is not very good. That's my view. Thank you very much.
Yes, thank you very much. Anybody else?
If I may, just quickly, I think my 10-second takeaway from this is it's been really great to hear all the different initiatives and innovations happening, and so good. I think there's lots of these things will have really good impact for mental health in COVID and beyond COVID as well. So I think that's really great to think about it in long term too.
Last call before I wrap up.
Can I jump in?
Oh, yes, please, Mikiko. Of course.
Thank you very much. Yes, I just want to highlight, echoing what Philip, you said, that the importance of preparedness. So, of course, better return is one very important aspect we should keep on, but also preparedness for any future crisis, including the health crisis and other crises. Thank you.
Well, with that, I'm going to very briefly wrap up and share my final thoughts, which are that this was a very rich webinar. It generated many references to good practices and certainly raised a lot of the issues concerning mental health that are lacking and that need to be improved on short term, still in emergency mode, but also, as Mikiko again underscored, in terms of preparedness. And all this in the context of paying attention to human rights and to each person that is affected by this pandemic. I think we should not kid ourselves. I think we're all in agreement that this COVID-19 crisis found many mental health and health service providers flat-footed in the face of the severity and the length of the crisis. And we've been all playing catch up in many ways. And many of the programs and ideas that are presented today must be scaled up and how should I put it, metastasized to cover many more communities and underserved populations. But again, there's a lot of distress, psychological distress, and there are a lot of vulnerable persons who are bearing the brunt as we speak of the human rights effects and mental health effects of this crisis. I think we could have done a lot better, and we need to do a lot better. And to pick up again on this idea, we need to reflect on how we build resilience into our societies, to be better prepared to confront what many predict are unavoidable future crises, some of which will be intertwined with the fast approaching major climate change disasters. And I think this webinar played a role in thinking about this. And for sure, I think that one thing is that there needs to be a sort of a mental health governance reset. What we did today sort of highlights what we can do better, but we need to think about transformation into better tools for the future. And I think that also this webinar was very helpful because, as you know, it's the first of a series of webinars, regional, and this is the first spark of a global thought process, and we all think more intelligently when we're in groups, and so there will be some cross-pollination of ideas which will come out of this webinar, and I hope the audience beyond the panelists and the participants will be able to have some takeaways with our contributions. So thank you to all the panelists, to the discussants. Special thanks to the OHCHR organizing and support teams. And of course, a shout out to all of you who have been following the discussions wherever you are. So from my end, goodbye, and I'll turn it over to Arnaud if he would like to say a few words to close the webinar.
Thank you very much. I would like to thank you for the moderation. It was extremely interesting. I learned a lot. Thank you to all the panelists. This really was a great learning curve for me. I would like also to share the participants, and I would like to also let you know that if you want to share additional documents with us on this topic, you can still send it to us by email. So thank you very much to everyone, and have a nice afternoon or end of the morning.